Hello, everyone, and welcome to this webinar on enhancing patient experiences, outcomes, and supportive care in neuro-oncology. This is an outlook from nurses and allied healthcare professionals organized under eEANO. My name is Karin Pihl, and I'm Associated Professor and Nurse from Copenhagen University Hospital in Denmark. And I'm chairing this webinar together with two of my peers. And please introduce yourself. Marika, please.
Hi everyone, I'm Marieke Donders-Kamphuis and I'm a clinical linguist from The Hague and Rotterdam in the Netherlands.
Thank you. And Florine.
Hi, I'm Florine Boele. I'm an Associate Professor of Medical Psychology at the University of Leeds.
Thank you. And next slide please, Florine. So we have 5 speakers for you today. 4 speakers are having live presentations and 1 will be held as a recorded presentation. And after these presentations, we will have a question and answer session, and you will have the opportunity to enter your questions for the speakers to respond to. Next slide, please. So please be aware that you can send in questions at any time during this webinar. Just use the question and answer button at the low bar, and we will collect these and address them during the question and answer session after the presentation. You should know that everyone will be muted during the whole webinar as a participant, and you will also be able to see a recorded version of this webinar, and it will be available at the eEANO website and on the YouTube channel of eEANO. And then over to you, Marieke.
Yes, today we have 5 speakers, as Karen already said. We start with Lina Rosenlund, a research nurse of Sweden, followed by Isabel Ruden, neuropsychologist and PhD student also from Sweden. Third speaker is Eve Williamson, a consultant neuro-oncology radiographer from the United Kingdom. Then followed by Diane Leake, occupational therapist all the way from Australia. And our last speaker is Sarah Mellish, speech and language therapist of the United Kingdom. And after these presentations, we have a Q&A session. So please prepare some questions and you can put them in the Q&A box. And let's start now with the first talk. And that's from Lina Rosenlund. So it's over to you, Lina.
Thank you, Marieke, Karin, and Florian. I will share my screen. So thank you, and thank you for, wait a little bit, I'll just move one thing. Thank you, eEANO, for arranging this webinar. I'm a registered nurse since 1997 with a clinical background from a neurosurgical ward and as a contact nurse in a neuro-oncology team at Karolinska University Hospital in Sweden. I did my master in nursing science and just finished my PhD studies with a focus on person-centered care and how this can be measured. Right now, I'm working at the Regional Cancer Center in Stockholm with patient-reported measures in different projects and national registries. My presentation will briefly introduce you to nursing in neuro-oncology. In relation to this presentation, I declare that there are no conflict of interests. In Sweden, the nursing education is a 3-year full-time program that leads to a Bachelor of Science degree in nursing. Thereafter, there are several postgraduate programs for a Master of Science with a specialization in a certain area of expertise, such as oncology, surgery, neurology, or palliative care. There are also separate courses such as for contact nurses, caring for people with cancer. We have 7 neurosurgery clinics covering the 6 regions in Sweden. All larger university hospitals have neuro-oncology teams, and all patients are diagnosed via multidisciplinary conferences. There are national guidelines and a national quality registry for tumors in the central nervous system. And we have a good collaboration with the Swedish Brain Tumor Association, who is involved in different of our working groups. Nurses within neuro-oncology are found in many different specialities and are important as a brain tumor diagnosis presents unique challenges for both patients and their family members. A brain tumor is often discovered after a sudden acute event, such as a seizure, cognitive or personality changes, or other neurologic or stroke-like symptoms. After a confirmed brain malignancy diagnosis, patients may be admitted emergently or within 2 weeks for surgery and then discharged to a rehabilitation facility or home. Depending on pathology, patients' wishes and performance status, patients continue on a path towards additional oncology treatment and rehabilitation. As the disease proceeds, home care and palliative care teams are often involved. In Sweden, we have a nursing role similar to navigator nurses as they have in the US or as in UK, Macmillan nurses. Every patient is offered a named contact nurse, and these contact nurses are also equally offered to family caregivers or close friends and are part of the neuro-oncology team. The contact nurses, the patient should have special access, and the contact nurse can refer to other contacts also when not available. They should inform about the next step so the patients always know what to do or what's happening next. They also provide support to both patient and family and close friends in normal crisis reactions. They also encourage patient and caregivers' participation and influence in their care. And they are also responsible to establish an individual care plan and also for active handovers to any new contact nurse in the continuum of care. Patients with neuro-oncology conditions are unique regarding the physical and cognitive side effects and also the potentially terminal diagnosis. A person-centered approach means that healthcare professionals, patients, and family caregivers co-create their care. And the aim is to find a common ground and understanding to create a personalized health plan. The Swedish National Cancer Plan states that patients should be offered both oral and written information regarding treatment and care, including survivorship care planning and rehabilitation in a care plan. The care plan that we use is developed by a group of contact nurses and patients from the Swedish Brain Tumor Association, and the care plan is initiated at diagnosis and are adapted to the patient by the contact nurse. The care plan should include contact information, time schedule and information of the medical procedures and treatments, survivorship care and the rehabilitation plan, and self-management advice for the patient. To support communication, there are also a chat or email function and a toolbox of questionnaires to use for holistic needs assessments and symptom management. The care plan is available on paper or as a web solution. The needs of brain tumor patients differ from those of other cancer patients, and their needs are often unmet by existing resources. Therefore, person-centered care and continuity is of importance. Person-centered care means involvement of both patients and people important to them, both formal and informal caregivers, to ensure the patient and family has the best support available for them. During the path, having the right care at the right time is of importance and something the contact nurse and the rest of the neuro-oncology team are looking for. The importance of involvement of family, friends is also because of they are the best support for the patient. And they also the ones who support the patients in daily life. Another thing that is very important when you meet the patient is that they really want to know what they can do themselves. So self-management advice, how to do their own rehabilitation, if they want to eat something particular, and everything that you can listen from the patient is of important and should be part of the plan. All this is due to the quality of life of the patients. I wrote continuity as an important thing in neuro-oncology care because I think these people need special treatment all the way, and continuity can support them to have someone they can access all the time. Another issue that is so important is safety. To be sure that the patient can actually take the medicine that they should, or they take the medications as they can, you need to maybe sometimes involve both caregivers and home care facilities. Another thing about safety is the transportation. Many people with malignant brain tumors are not allowed to drive their own car, and therefore they need help from family and friends. Another best of support could be peer patients, and the patient association in Sweden are very eager to be involved to support these patients also. Some people want to meet peer patients, but some people just want to read what other people have been involved in or their treat. This quotation is from a friend of mine and shows the importance of having a contact nurse or someone else during the care path. The contact nurse, their role in cancer care can't be stressed enough. They helped us throughout so many of those steps, and they gave an immense sense of security. We could call them and they gave us answers. They asked a bit about how you were doing, gave you a warm tap on the shoulder, and it became a little bit of a family. Otherwise, you're pretty much left on your own. Thank you for listening, and please feel free to contact me if you have any questions.
Thank you, Lina, for the interesting talk and the questions we will do at the end of the webinar. And now we switch to our next speaker, and this is Isabel Ruden from Sweden.
Okay, thank you for inviting me. My name is Isabel Ruden, and the topic for today is neuropsychological assessments in neuro-oncology, enhancing patient insight. So I was asked to give a short background about myself. I'm a clinical neuropsychologist working with brain tumors patients since 2014. I work in the brain tumor team at the neurology department at Sahlgrenska University Hospital in Gothenburg, Sweden. My clinical work is mainly to do neuropsychological assessments for patients with brain tumors. I have a background as a licensed psychologist, and then I've done some specialist courses in neuropsychology. So in Sweden, you can do either a specialist thesis or a PhD. So since 2019, I'm a doctoral student, and I focus on low-grade gliomas and the functional outcome following treatment of low-grade gliomas. So mainly it's a longitudinal study where I try to assess all presumed low-grade gliomas before and after surgery up to 5 years. And my clinical work is closely related to research, different kind of research projects. For example, we have a long-term follow-up on patients treated for brain tumors during their childhood. We have a supramarginal study on high-grade gliomas, etc. So as a neuropsychologist in neuro-oncology, I get most referrals from my own department, mainly from the neurosurgeons and neurologists, but also from oncologists, endocrinologists, and primary care physicians. Typically, patients with low-grade glioma come for pre- and post-operative evaluations, and also with long-term follow-ups. So I see other types of tumors as well, such as high-grade gliomas, meningiomas, pituitary adenomas, and those experiencing late effects after treatment. I also see patients that are candidates for awake surgery, and then also perform the intraoperative assessments. These patients are usually have tumors in their language eloquent areas. So I also do evaluations of fitness to drive, but more commonly I give recommendations to patients regarding return to work and how to better handle their everyday lives. So from the neuropsychological evaluations, I try to understand when and why symptoms have occurred, to understand what is changed and if symptoms are permanent or not, and provide feedback about this to the patient. Patients that have a good understanding of their functioning are more likely to succeed in making the changes that are needed to reduce their symptoms. So neuro-oncological patients commonly experience cognitive deficits and fatigue. So when I do my neuropsychological evaluations, I start with an interview where the patient and relatives are usually present. And here I try to understand how the patient functioned previously and what resources they have. So by talking to the relatives, I get a chance to find out more about possible changes in personality and how the patient's family members are doing. And before the cognitive assessment, patient get to fill out different kind of self-assessments, usually about depression, anxiety, and fatigue, but also sometimes about personality. This is like a more standardized way of getting to know more about factors that might affect cognitive functions. And then I do the cognitive testing, which takes about 1.5 hours. And then I compare the results to normative values and to the patient's presumed previous levels, or if I have done a previous assessment, of course, I compare it with that. Yeah, and during the evaluations, I also make observations and try to see if the observations matches the information from the interview and self-assessments. I get a chance to see things like the patient's problem-solving strategies, their frustration tolerance, impulsivity, judgment. I can see how the patient handles instructions and stress, their ability to correct mistakes and to reflect about their own performances. And this tells me a lot about what strategies might be appropriate and what problems the patient might have using strategies. Yeah, and then I make the interpretation, of course, meaning I try to figure out what the results really say, if the patient have a real deficit or not, and if they're old or new. And based on the interpretation, I provide feedback. Usually I tell what can be trained and what needs to be compensated and how. I try to base my feedback on concrete situations in the patient's life, such as going to the store, being at a social event, or at work. I think it's also important to tell the patient what they can expect is not possible to compensate for fully, such as personality changes and memory functions. Yeah, and I work close to my team members and often refer patients to other people in the team for example, emotional support, economical help, or follow up on medications or adjustments. Yeah, in our team, we also have we also talk about parents about how to talk to children about cancer and brain tumors, and we offer the children to visit us if they want. And within our team, we can also offer help to relatives. So I would like to give you an example of how a patient can experience a problem and how the neuropsychological evaluation can be helpful. It's quite common that patients have subjective complaints that are not really correct. Often this makes them worried and stressed. So a neuropsychological evaluation can be a way of enhancing insight by showing where the problems occur and what to do in different situations. So in this example, a patient has been diagnosed with a IDH mutated grade 2 astrocytoma, and he's had surgery followed by radiotherapy and chemotherapy. And this patient really wanted to get back to work and has recently tried to. And he describes that it didn't work out, that he couldn't get things done, but he was still exhausted at the end of the day. He says that he's worried because he walks around with a feeling that he has forgotten something all the time and think that he has memory problems. So I make the neuropsychological evaluation, where the self-assessment showed that he has a high level of mental fatigue. He has some anxiety, but no depression. And he also has some problems with his sleep. The cognitive testing shows that he has attention deficits that become more prominent over time as he gets more fatigued. He has no problems with learning and memory, but are easily distracted or disturbed when surrounded by noise when trying to learn. He tells me that he likes his work and has a good relationship with his employer and his co-workers. He's known to have many great ideas and has come up with lots of great things over the years at the company. However, when asking about the current situation, it seems he has problems getting started, are easily distracted, have problems prioritizing his work, and of course also to finish on time. So the feedback he gets is reassuring in relation to having a memory deficit. I explained to him how his problems with attention is worsened when he's fatigued. His days at work have been long and working half-time would be more appropriate. I also recommend that he change the start of his working hours to 1 hour later in order to get a bit of rest before going to work. Or if he had a rough night with sleeping difficulties, for example, and also to avoid the first hours at the office where there are lots of people and lots of noise. I also advise him to keep a routine of coming to work at the same time every day and keep his schedule as similar as possible to reduce the feeling of having missed something. And we go through some of his working tasks and make adjustments like dividing them into subtasks, include taking micro breaks and avoid too complex tasks. I also advise him to talk to his employer about avoiding deadlines and tasks that colleagues are depending on at this moment to lower his level of stress and anxiety and make his situation more manageable. So together with his employer, he will also look through what can be done at the office to optimize the environment, to avoid distractors and noise. And since this patient has a problem finishing on time, we decided that his employer will keep a close contact with him and have regular check-ins, especially in the beginning, to make sure he's on the right track. And this patient has recently finished radiotherapy, so the fatigue is expected to be better, even though he might not get well, which I, of course, tell him. And after our meeting, we have a telephone follow-up and possibly a new appointment for a new assessment within 6 months to see how things are working out and to better tell the patient about what to expect in the future. So as showed in this example, we try to give feedback to the patient to enhance his insight. And in our team, we work from the concept of a sense of coherence to promote well-being in patients. When meeting neuro-oncology patients, life is, for them, life is suddenly very unpredictable, and we try to help them to find something to hold on to set goals and provide them with correct information and realistic expectations in order to make the situation more comprehensible and predictable. We also try to make the situation manageable by having a close teamwork and being available for the patient. And by being available for the patient, we can provide them with a psychological security. We also try to make life manageable by looking at what resources the patient have in terms of support, function, and economy. And we also try to support patients into finding what is meaningful in their lives. So I hope this has given you a better understanding of what neuropsychological assessment is and how it can be used to enhance patient insight. Thank you for listening.
Thank you, Isabel, for your talk. Now we switch on to Eve Williamson. She's a consultant neuro-oncology radiographer, and her presentation is titled Embracing Skill Mix in the Neuro-Oncology Workforce, Capturing the Impacts of a Consultant Therapy Radiographer for Brain Tumor Patients. And her presentation is a recorded one, but she will be join us at the live for the Q&A session.
So good afternoon, everybody. Thank you so much for the introduction. My name is Aoife Williamson. I'm a consultant therapy radiographer working in neuro-oncology at the Beatson in Glasgow. And today I'm going to talk to you about capturing the impacts of a consultant radiographer and what this means for our brain tumor patients. I have no conflicts of interest. So as we all know, radiotherapy is central to the management of brain tumours. Therapy radiographers, as we are known in the UK, or radiation therapists, as we are known in Europe and Australia, Canada and New Zealand, we deliver the radiotherapy for our brain tumour patients. And we are the only healthcare professionals qualified to plan and deliver radiotherapy. Now, for those of you who are not familiar with radiotherapy, the image on the right is an image of a linear accelerator, which is the machine that we deliver our radiotherapy with. And we have really advanced technology in radiotherapy currently, and this allows us to safely deliver precision radiotherapy for our patients. Now, to become a therapeutic radiographer, we have to do a 4 years BSc honours course. This course involves physics, maths, anatomy, physiology, radiobiology, and once we complete that course, we can work as a therapeutic radiographer. Now, for somebody like me who's moved into advanced practice and a consultant practice role, we then have to go on and do a master's in advanced practice in radiation and oncology. And now in my role as a consultant radiographer, my responsibility is to provide a seamless pathway for patients receiving radiotherapy. I need to ensure that I act autonomously, that I'm an expert practitioner in neuro-oncology, and my responsibility is to assess, treat, and follow up patients with brain tumours in my department. So when we talk about advanced practice, we always talk about the 4 pillars of consultant practice. And when I was thinking about putting this presentation together, I was thinking about how do we change this around and how do I actually demonstrate what I do for my patients? So what I decided to do is, as opposed to we talk about domains from clinical practice, I'm going to use these domains to demonstrate patient-centered care. And I'm going to describe 3 of these boxes, so expert clinical practice, professional leadership and management, and research and development. And I'm going to demonstrate how I, as a therapeutic radiographer, enhance patient experience and outcomes. So firstly, expert clinical practice. And hopefully this is going to demonstrate how I enhance patient experience. So back in 2010, I've been doing my role for a long time, our nurse specialist that I work with, Mary McKinnon, and I felt that our patients were attending the radiotherapy planning appointments, and they really didn't have much information about what they were attending for. When the patients meet our clinical oncologists in Glasgow, they meet the patients just after they've been informed of the final pathological diagnosis. And patients at this appointment are very upset, and they're busy trying to process what this means for them when they have a diagnosis of a high-grade brain tumour. And they don't retain any information about the treatment plan. So Mary and I implemented a pre-treatment assessment clinic, and this clinic takes place approximately 2 or 3 days after the patient is seen by the clinical oncologist. And for this appointment, we invite the patient and their family to attend our clinic, where we discuss we undertake a clinical assessment of our patients. We discuss the medicines that the patients are on and make any modifications to medicines. We discuss rationale for radiotherapy. Mary discusses rationale for chemotherapy. I talk about toxicity profile of our treatment, and we also obtain consent for our radiotherapy treatments. And what Mary and I certainly found since we implemented this clinic is that patients now attend for their planning appointments and they understand what's going on. And in turn, that reduces the stress that they are under and the anxiety they face when they enter our department. So this is something, as I said, we've been doing for a while, and we've got really positive patient feedback about how this clinic enhances their patient experience. Another area of expert clinical practice that I'm involved in is our radiographer-led brain metastasis clinic. Now, this clinic was set up a couple of years ago when I became a consultant radiographer. And really, one of the main aims of this clinic is to ensure a fast, efficient referral process for our patients. We like to deliver radiotherapy to brain metastasis when they're small, and speed is of the essence of seeing our patients in the clinic. So within this clinic, my responsibility is to describe the rationale for our stereotactic radiosurgery treatment. I talk about a toxicity profile of our treatment. We ensure that these patient appointments are about an hour in length, and that really gives patients an opportunity to ask questions, to talk about their concerns. And by doing all of this, hopefully we're ensuring shared decision-making for our radiotherapy treatment. And certainly after we implemented this clinic, we undertook a patient experience survey, and we asked the patients lots of questions about how they found the clinic. And I've just given you an idea of some of the questions here. So firstly, we asked, was the proposed treatment clearly explained? And you can see that 90% of our patients agreed that they thought that the treatment was clearly explained to them. Was the information given easy to understand? And 95% of our patients said yes, that it was. I was given time to talk about my concerns. So again, 90% of our patients said that they felt they had appropriate time to voice their concerns about the treatment. And I felt involved in my decision-making about my treatment. And 85% of our patients felt that they did. And again, hopefully this patient experience survey really shows that radiographer-led clinics can be successfully implemented, keeping the patient at the heart of everything that we do and ensuring that we have a positive patient experience. So now I'm going to move on to professional leadership, and a large part of my role is implementing advancements in radiation technology. In the last 10 years, our technology in radiotherapy has come on so much. And this is an example of a project that I did for my master's dissertation. And I actually did this back in 2013. It's something that we presented at ESTRO, which is our European Neuro-Oncology conference, or sorry, European conference, and something that we published on. And basically it's comparing our old radiotherapy technique with a new radiotherapy technique. So again, I know that some of you will not be familiar with these, so I'll talk you through these images very quickly. The area in red here, it refers to the target volume for meningiomas. And a meningioma can be quite difficult to treat because it grows along the meninges of the brain, and we can have very irregular treatment volumes. So with our old technique, we've put on the high dose area here, and you can see that the area in red, the unusual shape, there's a lot of high dose area actually being delivered to the adjacent brain with this 3D conformal radiotherapy technique. And again, when we look at the coronal and the sagittal, you can see that that dose goes out beyond our target volume. But when we implemented volumetric modulated arc therapy, which is a new type of radiotherapy treatment planning and delivery technology, you can see that now when we look at these, you can see that the target volume with our high dose area is much more conformal. And again, when you look at our sagittal and our coronal images, you can see that the dose conforms nicely to the target volume, and that high dose area is no longer into the normal brain. So once we analysed the results of this study, we successfully implemented volumetric modulated arc therapy for our patients in our centre, which in turn we hope has improved patient outcomes and of course reduced the toxicity profile for our patients having radiotherapy. Another project that I led on was a hippocampal sparing radiotherapy project. The hippocampus is a complex structure. It's embedded deep in the temporal lobe. And these images here, the first one shows you a coronal view of the hippocampus, and you can see that's outlined in red. And we actually have two hippocampi, one on the left and one on the right. And the hippocampus is responsible for short-term memory, concentration, and our ability to learn. And when patients have temporal lesions, the hippocampus can be included in the target volume. And we know that radiation-induced damage to the hippocampus can play a considerable role in neurocognitive decline of our patients. So for this project, I wanted to explore newer techniques in radiotherapy and see if we could reduce the dose down for our hippocampal patients. So again, here's some images from the project that I led on, and you can see the image on the left. Again, I'll highlight out the target volume, this area in red, and you can see how the dose goes from red to yellow to green, and that signifies the dose fall off. So the area in red is the 100% of our dose, and then the area in blue is anywhere between 10 and 20% of the total dose. And you can see when we outline the hippocampus, but we don't employ any hippocampal sparing techniques, you can see the mean dose for both these hippocampuses was 15.1 gray. But when we implement a volumetric sparing technique, you can see that we can shield the dose nicely off both the brainstem and the hippocampus actually, and we could substantially reduce the dose down to the hippocampus using this modern technique for radiotherapy planning. This is another patient that was included in our study, and this time we have a left temporal oligodendroglioma. And again, you can see that when we don't employ any sparing technology, the mean dose to the left-sided hippocampus, is almost 24 gray. But when we employ our sparing technique, we can bring that dose right down to 7.7 gray, which is again a considerable saving. So again, we did this study, we published our results in Estro and wrote it up for publication. And again, we successfully implemented this technology for our patients. So currently all grade 2, grade 3, and now in the next few weeks, grade 4 patients in our department will be having hippocampal sparing technology for their radiotherapy plans. So again, just another example about how therapeutic radiographers can lead research projects which go on to trying to streamline and improve our radiotherapy planning techniques for our patients, in turn, hopefully improving patient outcomes and reducing our side effect profile. So finally, to move on to the last domain of practice, and that's research. And I am a National Research Scotland Fellowship. I have a fellowship which I wanted to look at, particularly elderly glioma patients. And I'll draw your attention to the images within this box. So this is actually images from a paper that was published back in 2020 by Dr. Verhoef and his team in Utrecht, but it really highlights what we want to do within our study for my fellowship. So here we go. Here's an elderly patient, and the area in red is a target volume. And you can see the high dose area within that target volume. But when we look at the lower doses of radiation, you can see that the normal brain probably receives anywhere again between 10 and 20% of the total dose. And within this study, they looked at the baseline MRI scan, so the pre-radiotherapy imaging, and they looked at the changes in the white matter tracts for these patients. So they did a baseline MRI scan and then a follow-up MRI scan 8 months after the radiotherapy. And you can see the areas in white here. You can see that there's been a reduction in the white matter tracts. So there's been demyelination of the white matter tracts in all these different areas in the brain. And these areas are distant to the target volume. So the radiotherapy in some way, even though we're targeting our target volume so precisely with our radiotherapy, any low dose to the normal brain is having these demyelination effects on our white matter tracts. So what I want to do is I want to have a look at radiotherapy dose and volume, and I want to look at MRI imaging features, and hopefully that will help us to predict the severity of neurological toxicity in elderly GBM patients in my department. So how are we going to do that then? So I'm going to use a study that we are currently running in Glasgow, which Professor Anthony Chalmers is the chief investigator of. And this paradigm study looks at evaluating a drug called olaparib plus radiotherapy and temozolomide in newly diagnosed glioblastomas. Now, olaparib is what we call a PARP inhibitor, and PARP is a protein, an enzyme which helps damaged cells to repair. And Professor Anthony Chalmers in his preclinical lab has published data to suggest that if we inhibit PARP, then we'll have an anti-inflammatory and a neuroprotective result in our brain tissue. So our study aim for my fellowship project is to quantify the changes of brain tissue based on the MRI scans for these paradigm patients before and after radiotherapy. We're then going to quantify the neuroprotective effect of olaparib in terms of the volume changes in the brain structure. And then we aim to correlate this data with the quality of life patient data in the hope that we will see that olaparib adds a benefit and will reduce the changes in the white matter tracts and reduce the volume reduction in sensitive structures in the brain, so that we hope to again improve patient outcomes and reduce the side effect profile of our radiotherapy. So in summary from my presentation today, I hope that I've shown you that therapeutic radiographers are central to the delivery of radiotherapy. We know that we can lead neuro-oncology patient services, and we're key to the implementation of advanced radiotherapy techniques. And hopefully by doing that, we can enhance our patient experience and hopefully our patient outcomes. Thank you so much for listening. Any questions, please contact me via Twitter or my email. Thank you so much.
Thank you very much, Eve. Our next speaker is Diane Legg from Australia, and she will be giving her perspective related to occupational therapy in supporting patients with brain tumors. Just as a reminder, you can, if you have a question for any of the speakers, just use the Q&A box. Thank you.
Thank you, Florine, and thank you very much for the opportunity to speak to this webinar, and thank you, eEANO. So my name's Diane Legg, and these are my affiliations. I'm involved with the Olivia Newton-John Cancer Centre at the Austin Health in Heidelberg, Victoria, Australia, also La Trobe University, and I'm currently a PhD student or a candidate with Curtin University, and involved as an investigator with the Brain Survivorship Project in Australia. So I'm going to talk a little bit about my journey into brain cancer care coordination. So it's a little bit unusual, I suppose, as an occupational therapist. I trained at a time where purposeful action and the maximising of potential and meaning making were really part of the way I trained, and my experience over that period of time was really born in ABI. I also worked in mental health for quite a period of time. So I really came to this role in care coordination as a generalist, really specialising in that chronic catastrophic injury that was either from some sort of neurological incident or work-related injury. So other things that I did to sort of bring me to neuro-oncology was I also worked in a number of home-based organisations. So where that sort of collaboration with patients and families was really intrinsic to the way you operated when you actually worked within people's homes. So I guess as a personal perspective, I bring a sense of curiosity and collaboration. And at the time that I trained, and I guess through my working life, I've really, having yourself as part of the intervention was a really important part of the way I trained. And so working with patients to help them, encourage them to be their own best expert was actually a really important part of that. So about 14 years ago, I had the opportunity to step into a brain cancer care coordination role. So this, in Australia, this would normally be filled, it's largely filled by nursing, but 14 years ago, there was not a lot of brain cancer care coordination going on. So this was a new role, and it ended up being developed through a philanthropic partnership with a construction union, actually. And they have had an ongoing commitment to the brain, support of brain tumour and patients and brain cancer patients, and they were very committed to developing a sense of family support and patient support that they saw wasn't available when one of their leaders was diagnosed with a glioblastoma. So that's how it developed, and we've had an ongoing partnership with the Cummins Fund for now 15 years. So my role in brain cancer care really forms 4 pillars, and we've really used those pillars as how we've developed the service. So it's around information, resources, support, and acknowledgement. So the information is really that classic patient navigation, targeted, timed information, not overwhelming people. So our service, the Brain Tumour Support Service, is involved from diagnosis. So we go with the oncology team to talk to the patients just after they've had neurosurgery about their diagnosis. Gives me a chance, or us a chance, to meet the patients, meet the families, to begin to develop that connection with them. So then we can arrange sort of that targeted, timed information, and that we can begin to get an understanding of what their needs are, and to be able to look in that sort of beyond treatment time to how they go on to live with this illness. I'll talk a little bit about building the bridge to life with brain cancer, which is a resource that we, our service, developed with a survivorship grant from the Victorian government, and that's an online resource as well as a hard copy resource that it really focuses on getting on with life post-treatment. So resources, we, I guess, really try to have our education programs that will build people's personal resource, a little bit like some of the other speakers have already talked about, that sense of people needing to have a certain amount of strategies in their toolkit in order to be able to deal with this the best way possible. We have a range of group programs, particularly focused around fatigue, also memory strategies and compensatory strategies around legal issues, around lifestyle. We also have quite a substantial support group program. And I think the important sense of that is that brain tumour patients and carers, it's important for them to connect with others and people like me. So having the opportunity for people to actually meet with others going through a similar experience is really important, that they can sort of build those self-supporting opportunities. So we run a monthly support group, which is face-to-face, and we've also right through COVID, we had online opportunities. We also run a carers program, which I'll talk a little bit more about in a minute. And then at different times, because we have a bit of flexibility, we can pick up with targeted groups. So for a number of years, we had a sort of an under 30s group, a young people's group. When we had I guess a critical mass of younger people. At the moment, we've got a young mums group, because we have about between just under 20 young women with primary school age or younger children who have been diagnosed with glioblastoma or grade 3 anaplastic astros. So they I guess sort of getting together online. Acknowledgement is the last sort of pillar, and I guess that really sense of acknowledgement of people needing sort of existential support, that an acknowledgement of that sort of cumulative grief and loss that can go along with the diagnosis, such as brain cancer. Part of our discussion when we see people individually can be around sort of developing some legacy activities. So we do a little bit of that through the support group and also through individual sessions with people. How I bring in the OT, I suppose, as sort of the day-to-day, it's really about that sort of needs identification and navigating to the appropriate service, whether it's rehabilitation or looking at physio, whether people need to go to dietetics, whether they need to go to psychology, but really that sense of promoting independence. Now, in Australia, we have a big new program called the National Disability Insurance Scheme, and that's become quite pivotal for our patients to be able to get appropriate services, particularly in that under 65 age group. So a lot of the care coordinators, and certainly myself being an occupational therapist, I write up plans for the National Disability Insurance Scheme, and that's sort of changed my work role a little bit over the last couple of years, and we certainly assist our patients getting onto that, really with the target of them really having an acquired brain injury. The other two main areas I guess I focus on in terms of being an OT is fatigue, and as I'm sure the other speakers will acknowledge, is one of the most common issues, and it would be the one thing that I talk to most people about. It's really critical to address. People need a strategy for it, regardless of what stage they are in their diagnosis and trajectory. It's really important that they can identify triggers, that they have some strategy to build, and that so we either do some individual discussions with people, but we also have a group that we run called the Fatigue Factor, which really works on that self-management, identifying triggers, working out a strategy, trying it out, having a few things in the toolkit to actually use. And I also do a lot of family education, because I think fatigue is something that's not very visible, and I think it can be really misunderstood. I guess very associated with fatigue and that contribute to it is that real cognitive load. And I do a lot of education with people around understanding what an impact, and I call it sensory overload, I suppose, that people with brain tumours, when they're in a busy environment, an example before that Isabel talked about, someone returning to work and being really overwhelmed. So that's what I would talk to people about with regard to them being overloaded in a sensorial way. And that really interrupts people's attention, their memory, their capacity to process information. That can be very difficult for them to then react in a usual way. So it can impact on behaviour and people's ability to communicate. So I often do a lot of patient and family education and really help them develop some strategies around that. And it's very closely interrelated with the fatigue. So that's my kind of quick snapshot of what I do is bringing in the OT. I just want to talk a little bit about caregiver support. As we know, it's a huge burden for caregivers, caring and supporting someone with a brain tumour. Often be high levels of distress, and that they are a really pivotal part of somebody's team. So a lot of what we do is try to definitely engage them very early in the process, really try to give them some space to talk about some of their individual concerns. We do quite a lot of troubleshooting with them. We do have some carer-specific services in Australia, which is great. We sort of talk through strategies about talking to children about cancer. What I found quite a number of years ago is that carers had some really important needs. So we actually pulled together some caregiver groups, and now we run those online, but we in the past we have run them face to face, and I guess we really got together a small group of people and calling it kitchen table wisdom. So that sense of just sharing what it's like to care for someone, what are some common concerns, sharing strategies, sharing ideas, giving caregivers a safe space. From time to time we do have patients, accidentally sort of photobombing the group, which we really try to cut out now, because it's important for the carers to have a really safe space to talk through. And we've found these groups to be really valuable. And I think it really helps with people's preparedness to care. It gives us the chance to provide really honest and open information about disease trajectory, what end of life's like, how you look after yourself, how it's important to self-care as you're going through this. So that's been a great program that we're sort of continuing with. And I suppose that's part of my passion is about improving caregiver resources. So just a sort of a little snapshot of what I've been involved in. So and I'm really passionate about improvements in neuro-oncology support and care. And to this end, 5 years ago, I did my master's study was around understanding how people accommodate low-grade glioma diagnosis, and the learnings from this led to the development of this resource, Building the Bridge to Life with Brain Cancer, which we did as a sort of a co-design collaboration with patients and carers and teams of allied health professionals. I'm involved in the BRAINS program, which is brain cancer rehabilitation assessment and intervention for survivorship needs program, and that's really developing some survivorship interventions and models in Australia. And part of my PhD, which I've just started this year, is really looking at investigating communication and part of what I found in my master's is really the need to investigate the communication, the language of health professionals, and part of my PhD program is really going to be looking at developing and testing communication skills package to use in the brain cancer arena, particularly with respect to carer engagement and also the challenges of cognitive changes with patients. So that's all I've got to talk to. I hope I haven't talked too fast, but happy for questions. And this is just a little snapshot of the resource that we're very proud of. So thank you very much for the opportunity to talk.
Great, thank you so much, Diane. Our last speaker today is Sarah Melwish from the UK, and she will be talking about speech and language therapy.
Well, thank you very much, eEANO, and thank you to Laurie for the introduction. It's been a bit of a long afternoon so far, so I hope you'll bear with me. Just one more to go. My name's Sarah. I'm a speech and language therapist with a special interest in neuro-oncology, and I'm a clinician, not a researcher. So I work full-time as a clinician in St Bartholomew's Hospital in London, and neuro-oncology is a part of my role there as an oncology SLT. But today I just want to talk very briefly about the role of SLTs in adult brain tumour populations. So I'm aware that in different countries, speech and language therapists have very different training and different roles. So I thought it might be helpful just to explain. Sorry, let me just get rid of this at the side. I can. Okay. To explain the training in the UK, to give it some context. So to be a speech and language therapist in the UK, you either complete an undergraduate degree of 3 or 4 years or a 2 years master's degree. Both routes lead to the same qualification and cover all aspects of child and adult communication and swallowing disorders. And the graphic here just illustrates the working environment of all SLTs in the UK, whether that's working with adults or children. Oh, why haven't you moved on? Oh. There we go. Let's try that one. I'm sorry about that. So why do we need SLTs in neuro-oncology? Well, looking at the highly complex symptom profile is quite a good place to start. So this data is from adults that are self-reporting symptoms using the MD Anderson symptom instrument for brain tumours. And it looks across the disease pathway from newly diagnosed to follow-up. And as you can see, there's a huge range of symptoms, and more than 50% of patients reported at least 10 concurrent symptoms. But if you look at those directly related to SLT, we've got difficulty speaking here, which is about 15%, and we've got difficulty understanding, which is about 10%, but no mention of dysphagia. Looking at a different set of data, this time it's from assessments by healthcare professionals rather than self-report. We can see a different symptom profile. Here it gives a prevalence of 27% for dysarthria, which is a motor speech disorder causing the slurred speech, 24% for dysphasia, but no difference between receptive and expressive, and 26% for dysphagia, or a swallowing difficulty. Now, I believe these values are likely to be an underrepresentation of the problem. Data collected at my previous trust, where we began screening patients for cognitive and communication deficits prior to the initial oncology consultation, showed that over 1/3 of patients had impairments at understanding spoken information just at single sentence level at the start of the disease pathway. So why the discrepancy? Well, people with communication difficulties are very often excluded from studies and even self-report data due to their comprehension impairments. It means they're not able to understand consent agreements, or often not even the self-report questionnaires. So we know our patients have complex symptom profiles, including communication and swallowing difficulties. But what does this actually mean for them? Well, eating, drinking, and communicating are absolutely fundamental to daily life. When was the last time you went through a day without doing all these things? And so here are some of just some of the impacts of the impairments in these areas. If you're looking at the medical environment, we talk about shared decision-making in healthcare. But how can we do this if we don't know the communication function of our patients? And it's just involved in so many areas of day-to-day living, work, social life. But especially for our high-grade patients, it's really important for end-of-life discussions and preparations, whether that's writing wills or letters to loved ones. And swallowing is about so much more than nutrition. The impact of dysphagia on social interaction and self-esteem is significant. So all of this leads to a significant impact on quality of life. So what can we do to help and support people with a brain tumour? Well, we can start with assessment, both objective and functional. We can inform the patient, the caregivers, and the whole multidisciplinary healthcare team looking after these people of what these results are. But really importantly, we can give functional support and therapy. Different approaches for low grade and high grade, but definite roles in both. And also we can educate, but we need to look beyond the patient, caregiver, and MDT to a broader audience. So if we look at assessment briefly, for an SLT, objective assessment using validated tools, they're really important for baseline measures. We're involved in awake craniotomies where surgeons will be working close to eloquent language areas. So we need that baseline function before we start. And the SLT are involved in evaluating language function during the surgery. But baseline assessment is also really key to inform support and identify change. Functional assessment in home and work environments is used to help identify functional goals with the patient. And although swallowing difficulties are not so prevalent in this population, objective assessments such as video fluoroscopy or FEES is still really useful with the right patients. However, functional assessment is often more widely used, especially at the end of life phase when swallowing difficulties often develop. Informing patients and caregivers of assessment findings is key. It allows them to adapt and prepare. It allows them to prioritise and to manage expectations. Informing all those involved in the patient's care of any communication deficits is so important to enable optimum participation for the patient in their treatment and care decisions. Please remember, a language impairment does not equal a lack of capacity. So if I had a clinical conversation, for example, about diagnosis and treatment options in Danish, which I don't speak or understand, I wouldn't be able to participate. I couldn't weigh up information and I couldn't make an informed decision. Does that mean I don't have capacity? Or does it mean the information needs to be presented in a different way? There's also some considerations to sharing this information. They're not easy conversations and not all patients want to know the information, and we must respect that. Now we come to support and intervention. This is just so important. I'm passionate about providing this support and intervention because we can't assess patients, identify deficits, and then not provide the support that's required to maintain or improve function and quality of life. There are so many ways SLTs can support communication deficits, and just a few are listed here. The approach is going to vary depending on the prognosis and the disease stage. For those with rapidly progressing high-grade tumours, the focus is often on communication partner training, adaptation, and functional support such as AAC, which is things like picture charts or something more technical. For those with lower grade tumours and good prognosis, restoration of function is more of a focus. A more traditional direct therapy may be used, but always working towards functional goals. For swallowing difficulties, texture modification may often be used as a patient deteriorates to allow ongoing pleasure from eating and drinking, whilst reducing but often not eliminating the risk. In other patient groups, swallow rehab may be more appropriate. Again, a part of our skill set and informed by our objective instrumental assessment. For education, I really believe we need to think beyond the patient, caregivers, and their healthcare MDT. Clearly, that's really important, as they need to fully understand how we can help and support. But we need to educate commissioners of healthcare services as to our role and value. That way, people with brain tumours will have access to our services. We also need to educate funding bodies to enable badly needed research, providing a more robust evidence base for our role and intervention within neuro-oncology. Quite a big ask, I know. I thought I would finish with a very quick case study of a gentleman who's quite typical of the patients I'm involved with. So this is his presentation history, a 68-year-old gentleman with a left temporal occipital GBM. He had a very supportive family. Sadly, it was 3 months from onset of symptoms to his first scan, but then everything moved very quickly. Note that in August 2021, the expressive dysphagia worsened, but it was prior to any progression being seen on the scan. And it just shows the importance of close monitoring of functional performance. So this was my intervention. I was involved in his initial oncology consultation to observe, where he was functionally fully able to participate. We then run an AHP clinic for similar reasons to Aoife explained in her therapeutic radiography talk earlier on, that it gives us time to actually answer more questions and away from that initial stressful environment. But we also carry out some assessment there. And this assessment identified mild expressive dysphagia in spoken and written modalities, mild receptive dysphagia in spoken modality. The patient was really keen to have some direct input to try and maintain function, and identified maintenance of family names and place names as most important to him. And he worked incredibly hard on that, and it did really make a difference to him. Also, there was the introduction and practice of strategies to use when having word finding difficulties, practicing these so that when the word finding difficulties became worse, the strategies were quite embedded. But also, really importantly, discussion around likely deterioration of communication over time and the need to ensure affairs are in order prior to deterioration. This might be writing letters to loved ones or making sure the will is complete. Regular reviews and support of practice and strategies throughout treatment and monitoring phase took place. But with deterioration, the patient was unable to access communication charts with poor object and picture recognition. So the focus was on advice to family. Regular reviews for dysphagia, which had developed towards the end of his life, were managed by diet and fluid modifications. It enabled him to keep eating and drinking small amounts, almost right up to his final days. He also needed to actually taste each item, as he couldn't recognize it visually, and that resulted in frequent refusal and real upset for the family. But being able to give the high levels of support to the family at this time really supported them with this. In the UK, SLTs are often not involved in palliative care teams, and community teams are unable to respond quickly enough. So I was lucky in my role that I was able to support all the way through from diagnosis to end of life. The patient passed away peacefully at home just under a year after diagnosis. That's a bit of a sad way to finish, but I think it hopefully illustrates the role that SLTs can play all the way through the patient journey. And I hope that gives you a brief insight into the role of SLT in neuro-oncology. Thank you so much for listening.
Thank you very much, Sarah. We can now begin answering some of the questions. I think I saw one earlier for Diane. Diane, what are your experiences with online support groups versus physical groups? Do you experience the same number of attendance? Is there a difference in preferences for support groups for patients and caregivers regarding online or physical attendance? So that's a question from the audience.
Yes. Okay. So I think it would be fair to say that online physical attendance is certainly something that builds over time, and there's certainly real value. And I guess I love running groups, and certainly the engagement is much better with the actual physical group. And up until the pandemic hit us, we had a monthly group where we would share lunch together, and we'd have up to sort of 16 to 20 people in a support group, which was amazing. People have adapted relatively well to online, and I think if we had have introduced an online group 5 years ago, I think that would have been a lot harder. Now it's a little easier, and I've got better at it. We've got better at it of engaging people, but it is, I think, harder work as a facilitator to draw people in. I mean, you can use more tools like presentations and things like that, or show videos. That's a little bit easier to do. What's been hard is a hybrid model, which has not been so easy. So we've abandoned that as a bad idea. So sort of having some people in person, some people online, that's been too hard. Yeah.
Okay, thank you, Diane. I have a question I received for Lina. And this, what do you think that's most important for patients when they are, in your role, when they are newly diagnosed with a brain tumor?
I think they really need to have someone with, from another oncology team to call if they have questions or issues. And also that the family caregivers are involved, they can help them with all information and decisions that they need to take at that time. I think in the beginning, there's so much information provided at diagnosis. And as Sarah also said, they might have both cognitive or language issues. And besides that, often a crisis. So they need all the support they can have, and also really important to involve their family care.
Shall I ask the next question? I don't know if maybe Karin had one, but I had one for Isabel. I found your talk really interesting because I have a background in neuropsychology, but I don't do clinical work. So I was wondering what of those tests or self-assessments that you use in the clinic, do you find them both useful for the clinic and for research, or are they really different tests or self-assessments?
So I use these tests from my clinical work in my research. So I think they fit pretty well. But on the other hand, I think when I decided the protocol, I of course looked at what has been published to use similar tests, or at least similar to cover the same areas. Yeah, so I think they work well.
Thank you.
So I have a question for you, Eve. So I'm really impressed by you setting up this pre-treatment assessment clinic in your practice. So could you please describe, did you face any challenges when you implemented it, or how did you actually do it?
I suppose it comes down to what's really important for, I suppose, a therapy radiographer working in neuro-oncology is all about the team. And I think I'm very fortunate I have a very supportive 2 clinical oncologists and a nurse specialist. And it was after Mary and I had worked in our roles for probably about a year or so that we identified this real patient need for this additional clinic. And really, once we'd actually written the business case and spoke to the clinicians and our business managers, they all agreed that this was the right thing to do. And actually, once we had decided to implement it, it was all pretty much straightforward. So I see the patient regarding radiotherapy, as I explained, and Mary does all the chemotherapy. Discussion with the patients and their families, and I think it works really well. having, you know, nurses explain kind of the chemo and the supportive care side, and then me explain the more technical issues with radiotherapy, because it's such an overwhelming conversation to have with patients and their families, and it always leads on to additional questions that they hadn't even thought about before they came into the consultation room. So yeah, no, it's been really useful, and certainly useful for Mary and I as well. At least then we know when our patients attend for their planning appointments for their radiotherapy, that they have the information that they need, and they can then have another opportunity to ask any further questions, which is so important.
Thank you, Eve. I agree, it's very important work you're doing. So I also have a question for you, Sarah, because I actually envy that you have a speech and language therapist for your patients, and I would like to have that too in Denmark. But is it normal procedure in the UK?
Oh, that's a good question. I think it's really variable. I think it's getting better, but it's definitely not normal. I think a lot of speech and language therapists are involved more in the surgical end of the pathway, and are definitely involved in awake craniotomies and assessing language function during surgery. But then the support tends to fall off the cliff a little bit when they come to the oncological sort of stage of the pathway. So when they're having the radiotherapy, chemotherapy and monitoring, but actually that's probably 90% of their pathway is as an outpatient. And that's where the support is really needed. It's getting much better because we have a very good initiative in the UK. We have something called the Tessagel Brain Cancer Mission, and they have taken it on themselves to try and drive support and care for brain tumour patients. And one of the things that they've identified in multiple centres in the UK is a lack of speech therapists. And they're really trying to drive AHP provision generally in the UK. So it is getting better, but it's still not good enough when you consider the prevalence of the difficulty in these patients and the support that's needed literally all the way through the pathway. Hence the education of commissioners and research funding bodies. We really need to raise the profile a bit.
Okay, thank you, Sarah. From the question box, we have another question to Isabel. And it's about, in your presentation, you mentioned that you also have the opportunity to help the relatives. And what kind of help can you offer?
Yeah, from my side, it's usually, I usually see the relatives together with the patients when providing the feedback from the assessments, trying to explain to them how this, for example, affects their relation or their functioning in their family and so on, or just answer their questions about functioning. But we also have social workers and counselors in our team that can give them that can have like contact with them, and also we have this, as Lena said, these specialist nurses that we call contact nurses here in Sweden. They are available for both patients and relatives.
Lena, do you have something to add to talk of Isabel about the care for the relatives?
They really need some.
Lena, I think you have to raise your sound so we can hear you better. Or maybe take your headset.
I forgot this one. As I said before, I mean, involving the family or friends or close ones to the patient is of most importance, because I think it's important for how they communicate at home and how they can support the patient, if they can actually understand the behavior or why the patient is acting in a way that they maybe not normally do. And so I envy you that you have such a good assessments of your patients, because I think it's very important, and that you also involve the family caregivers to actually see the results. I think this is a very good way to, as you also said, the preparedness for what actually can come. And because I guess you're a partner from the beginning, and then you become more and more a caregiver for the patients.
Mm.
So I have a question for you, Diane, because you mentioned that you have some focus on children as relatives, and that you focus on how to talk to parents being sick about what to say to the children. Could you elaborate a little bit about that, please?
Absolutely. So I think early on in my work, I saw a lot of really difficult and sad situations where children hadn't been told, and people were being admitted to palliative care, and you know, partners were still saying, "Oh no, Daddy's coming home," and it was just very very difficult and tragic. So what we try to do is develop a bit of a strategy with families. We have run over the years sessions with the social workers about the strategies of talking to children. We have a great resource in Australia that is developed by the Cancer Council. It's called Talking to Kids About Cancer, and it's a great resource that I guess talks about the different age groups of children and what they understand and how they conceptualize health and illness and death. And it sort of helps reassure families. So I usually help go through some of that information. I give them the resource, I help them go through. I also encourage the parents to think about who in their support sphere, like if the children are at school, who are the teachers that the kids connect with, if there's counsellors or psychologists or attached to the school, whether they can know about what's going on so that they can sort of watch out. I don't, partly because there's not loads of child psychologists in Australia that are public access. So I don't say, no, the children must go off and see a psychologist. I think sometimes it's about who in their local, in their sphere is already available for them. So as I said, school counsellors, family, friends, aunties, uncles, people that they connect with to help talk to the children or check in with the children. I guess what we try to reinforce is that children know something's wrong. So not reassuring them, because if they don't have a little bit of information, they will make it up, and that will be what they will make up will be much worse. So I think we really try to encourage people to have to start that conversation with children. And so based on what the Cancer Council recommend in terms of age groups and things like that. So that's often the mums group. That's often what we talk a lot about.
That's actually what we do here as well. Very much the same. Yeah.
Yeah.
I see someone in the webinar participant asked if you could share the link to the resource, if that's possible. Sure will be of interest to many people listening.
Absolutely. I will locate it and try and put it in the chat. Yeah.
So I was also wondering whether it's normal to offer these care plans to our patients, like Lena told us about in Sweden. Do you also have a care plan in Australia and in UK, the Netherlands, and so on? No, it doesn't seem. Sarah?
I'll comment. Yeah, certainly in the UK, there's a lot of intention to have sort of individualized care plans, but and all treatment options are discussed, and everything is sort of put on the table, and patients are very much encouraged to be involved in that. But I don't think it's quite as formalized as Lena was describing, and we certainly don't always give them written information about their individual care plan. And I think it's something that I'm very interested in, is actually, you know, how much, you know, our patients actually take away from those discussions. You know, a lot of them obviously have communication difficulties, which we've illustrated, so they can't even access this information, but the oncologists aren't always aware of it. So I think it's quite a complex area, but it's something that needs to be developed more in the UK. I think there's a lot of talk about shared decision making and formalizing that process a lot more. But the fundamental sort of premise of that is that people can understand and participate in those discussions. And at the moment, a lot of them can't even do that. So I think there's a sort of a multidisciplinary sort of approach needed to this, but I think it's absolutely a really good way to go and a good model to sort of look towards.
In Australia, we have all the care navigators or care coordinators or care services have developed in all very different ways. So at the moment, we've got a lot of funding that's come through for a couple of big research projects looking at supportive care needs, and part of that is looking at care models to get it a little bit more consistent. So about training care coordinators or patient navigators about getting a consistent approach, because the service that I work in, there would be a handful of those throughout Australia. So, and they've just come up, and often it's not been something that's been funded through the hospital, it's been through a philanthropic partnership. So a community organisation has raised lots of money. So all the services have developed quite differently, and we're just beginning to pull it together now. Yep. I would love everyone to have a contact nurse. I think that would be completely awesome, but that's not something. And the same with, I suppose, some of the resources, like, you know, I can't remember the last time I referred to a speech and language therapist because they can't access them as outpatients very successfully. There's just huge wait lists, so it's just really tricky. Yep. It's just.
Yeah, that's why this network is very important, because we can be inspired from all the different roles, and we could have many other professionals joining this webinar, for example, social worker and physiotherapist. So it's very important that we have this network. So anyone else have a question or something they want to say? Okay, so it's time to end this webinar, and I would like to, on behalf of eEANO, to say thank you for joining us today. We hope that you have gained an increased insight into the different and very important roles around the patient with neuro-oncological diagnosis. And also, we hope to see you in Rotterdam in September. Please sign up, join us for good discussions, and we will be happy to see you there. So on behalf of eEANO and our presenters, thank you for joining us today, and have a great rest of the day. Thank you.